Hi everyone, we're back. I believe this is part 5 of chapter 11, and we're going to start on IBS, which is on page 577 if you're interested to follow along there. So IBS is a disorder of the GI tract that's more functional, and your patients may present with pain and discomfort. To be considered for IBS, the patient must have two of the following features. So we talked about abdominal pain or discomfort, and this is relieved by having a bowel movement. If the patient has a change in the frequency of the stool or the appearance of the stool, more frequent stools, more than 3 per day, or fewer stools, less than 3 per week. If you're noticing that, or if they're communicating that they're passing mucus, the feelings of straining, urgency, or an incomplete evacuation, and issues with gas and abdominal distension. Women are traditionally more affected by men in this process, a 3-to-1 ratio, and approximately 9 to 20% of the general population suffers from these symptoms. Symptoms may present in early adolescence into early adulthood, late adolescence into early adulthood, but is rarely seen in the older adult. So regarding some pathophysiology on IBS, there's really no organic cause noted. It could be a possibility of some hypersensitivity in the visceral tissue. We know that the patient can have hypermotility, and up to 33% may develop IBS after having a bout with bacterial gastroenteritis. When your patient presents to you, they may present with two types of symptoms: abdominal pain and altered bowel habits, or having painless diarrhea. You may notice that they have abdominal distension, gassy, belching, dyspepsia, nausea and vomiting, urgent need to go to the bathroom, and physical exam is often normal. I forgot to mention they also may have heartburn, otherwise known as pyrosis. You may think that this is an easy condition to diagnose, but there is a criteria that is available to help in the diagnosis, and you can find that on page 579 in the book, but let's go over that. So those individuals that have the abdominal pain that's relieved by defecation or associated with change in the frequency or consistency of stools for 3 months, and then also included with that one of the following: defecation with patterns of constipation and diarrhea 25% of the time, and 2 or more of the following: altered stool frequency, form, altered sensory, active defecation, passage of mucus, and varied degrees of bloating and abdominal distension. When working your patient up, you're going to have several differential diagnoses to rule out. So you need to assess for food intolerances. Could there be any infection processes going on? Is there any endocrine disorders? Any medications that could be impacting the bowel consistency and motility? Any functional GI disorders, whether it's the upper GI or the lower GI, psychological disorders, and then if there's been any fat or bile acid intolerance. When we go to try to manage these patients, trying to identify the symptom pattern is very important. Addressing precipitating factors. So talk with your patient about what their food history is, about what their beverage intake is, and try to assess for things that might be impacting the IBS. This could be stress as well. It's important that they avoid foods that may exacerbate the condition. It's also important that they're on a high fiber diet, especially if they're having that loose stool, because that's going to help bulk it up, but also the high fiber, if they're constipated, is going to help with evacuation of that. The use of antidiarrheal medications can be used temporarily, but they're not for long-term use. Anticholinergics may slow the process down. And then the use of agonist or antagonist, such as your antidepressive agents, have been shown to help with some symptoms of IBS in individuals. There also is a component of psychiatric interventions that have been found to be helpful when you teach patient behavior modifications and biofeedback. These are very helpful alternative measures for patients that have refractory IBS. Follow-up with these patients is encouraged, especially preventing behaviors that can exacerbate the symptoms, such as those triggers in food or nutrition. And it's important to educate on the need for a high fiber diet, regular exercise, and avoiding of foods that can cause more issues. Next, let's talk about bowel obstructions, and this is the consequence of any condition that does not allow the flow of the intestines to move things through as it should. The chyme is the chemicals that flow through the intestinal lumen, and if that is blocked, then that is what's going to lead to a bowel obstruction. It can be a complete or a partial obstruction, and it can involve any section of the large or the small bowel. When it's a mechanical blockage, that's a simple thing that can be taken care of. If it's a functional issue such as a paralytic ileus, then we are also seeing a disruption in the motility of the GI tract. You have likely seen these type of patients in the hospital setting. Classification is based on when the symptoms started. So an acute may be caused by a torsion, a herniation, or an intussusception of the bowels. Chronic could be a gradual onset, usually from a tumor growth or from strictures, and then also there could be a complete or a partial obstruction. Pathophysiology, we identified that with the distension, then there's this backup of fluid and gas related to the distension. The gas is a result of the bacterial fermentation and swallowed air in the gut. And the distension decreases intestinal ability to absorb the water and electrolytes, and more of that is left in the lumen, which is adding to the volume that is there. You can have as much as 8 liters to accumulate in the intestinal lumen in 24 hours. If you've ever had a patient that had a bowel obstruction and you put in an NG tube, it's amazing how much fluid and stomach content can come back out into your container. There is a definite imbalance of fluids and electrolytes that can lead to dehydration, hemoconcentration, and hypovolemic shock. And based on where the obstruction is located, you may see acidosis or alkalosis. And also, depending on what is the cause of the obstruction, arterial blood flow may be compromised, and this could cause ischemia, necrosis, perforation, and peritonitis. So you can see where having an obstruction in the bowel is a situation that needs to be attended to promptly. On your clinical presentation for the patient, they may experience a sudden onset of colicky, abdominal pain. There may be nausea and vomiting. Diarrhea may be early, but constipation may be later. You may see signs of dehydration. Of course, there may be the dry mouth, but you also may notice elevated heart rate. There'll be abdominal distension. Bowel sounds may be high-pitched and hyperactive, or you may not hear any bowel sounds at all, and a mass may be palpable. So when we go to evaluate these folks, diagnostic tools are important. You might start with a least invasive tool such as a abdominal x-ray, and that can be used to diagnose a small bowel obstruction. This will show the different levels of distension in the small bowel. Upright films show multiple air fluid levels within the loops of the small bowel, which can be indicative of a small bowel obstruction. And we also know that these abdominal films for someone with a large bowel obstruction usually shows distension of the intestines down to the level of the obstruction. So there's several things to include in the differential diagnosis. Could it be a pseudo-obstruction? Could you have a megacolon? Could there be some twisting of the bowel? Could there be a strangulated hernia? A kinking of the loops of a bowel that could be related to adhesions from a previous abdominal surgery? Could there be concerns for diverticulitis, Crohn's disease, or a neoplasm? Could there be foreign bodies such as gallstones or ingested objects that is causing the bowel obstruction? Then could the bowel have twisted back on itself? Could there be a paralytic ileus where part of that section, and the paralytic ileus is where there's that section has no peristalsis and nothing is moving through. So how is the best way to manage these patients? Often it is hospitalization and immediate referral. Laparotomy may be needed if there's a complete bowel obstruction. It's important to hydrate and offer electrolyte replacement, and then discontinue any medications that may decrease intestinal motility. As we talked earlier, putting down an NG tube to decrease passage of secretions. It also helps in decompressing the bowel and helps with any vomiting. These patients are going to be referred to a surgeon if there's a suspected bowel obstruction. It's important that if there is continued recurring abdominal pain, that they call and notify primary care or their surgeon. These patients will often be put on stool softeners and then encouraged to refrain from any strenuous activity for 6 to 8 weeks. Next, let's talk about some diverticular disease. And this term is used to describe the inflammatory changes that can occur within the diverticular mucosa of the intestine. And that's called diverticulitis, as well as the asymptomatic, uninflamed outpockings called diverticulosis. So we know that these pouch-like protrusions in the intestinal mucosa are called diverticula, and they occur most often in the descending and sigmoid segments of the colon. They tend to form at a weakened area in the intestinal wall, and this is usually where arterial vessels perforate the colon. And that inner layer of the tissue protrudes through and forms a narrow neck, which is continuous with the inner layer of the colon, and the sac herniates through the muscle wall. And most diverticula are found incidentally when there's a scope being done or a barium enema. Diverticular disease is uncommon in the younger patient, less than 40. It's more common in developed nations. And although there is no known cause for the diverticular disease, a low fiber diet has been thought to be the cause, as it causes increased intraluminal pressure within the colon, which leads to the mucosal herniation through the weaker areas of the bowel wall. So let's talk a little bit about the pathophysiology of diverticular disease. As we mentioned, our low fiber diet, it is felt that this is a consequence of that and refined foods. So as stool bulk is decreased and the colon transit time is increased, this can lead to the development of diverticula. We know that there's increased pressure in the muscular portion of the wall, and this increased pressure can lead to a herniation in the bowel wall. Inflammation can develop due to the retention of undigested food and bacteria, and it can disrupt the blood flow and lead to an abscess formation. And that's when we get into diverticulitis, and that's acute diverticulitis is that localized inflammation within the colon or the peritoneum. On clinical presentation, your patient may say that they have left lower quadrant pain. They may have blood in their stool, fever, chills, tachycardia, rebound tenderness, and have guarding and rigidity on exam. Abdominal x-rays will be ordered, as they can show if there's any free air, indicating any perforation, if there's an ileus or an obstruction. A barium enema will outline the lumen of the bowel and showing any diverticula. And if there's concern for a perforation, a CT with oral contrast is going to be most sensitive. Also, a CBC is often done, but with this disease process is usually normal. Some of your differential diagnoses include IBS and IBD, colon cancer, lactose intolerance, pelvic inflammatory disease, an ovarian cyst, colitis, appendicitis, or pyelonephritis. As we mentioned, it is often an incidental finding and needs to be managed with a high fiber diet or a daily dietary fiber supplement with psyllium. Mild symptoms can be managed as an outpatient and can include rest, oral antibiotics, and a clear liquid diet. And if there is an acute illness with increased pain, fever, it will require hospitalization, IV antibiotics, pain medication, bowel rest, and possible NG tube placement. The type of antibiotic that may be considered will be dependent on the extent of the inflammation and it could be flagell, it could be Cipro, or it could be Bactrim. To evaluate and diagnose diverticular disease, all patients will require a scope at some point during the disease process, so it's important to get them in with a gastroenterologist for any symptoms that do not respond to treatment after 6 months. And patient education is very important to emphasize the component of a high fiber diet. All right, let's talk briefly about colorectal cancers, and these are tumors that can be both curable and preventable. They may have symptoms and they may not have symptoms. If there are polyps, they can be classified as hyperplastic, which are non-neoplastic, or adenomatous, which is neoplastic. And these are the precursors to malignant adenocarcinomas, which make up over 95% of all malignant tumors in the colon. And then there's also submucosal polyps, which are lipomas. There's been a noted decrease in mortality rates over the last 20 years due to improvements in screenings, diagnoses, and treatments, but there's also been an increased incident of colon cancers, and also those are seen in a younger population. So currently the American Cancer Society is recommending colon cancer screenings, colonoscopies, to start at 45. A little bit more about them. 9% of all cancer deaths in the United States are from colon cancer. The risk increases with age. The survival rate is anywhere from 50 to 55%. Japanese Americans who adopt a Western diet have higher rates than traditional Japanese, and risk factors include a family history and then a diet high in fat, red meats, and refined carbs, and low in plant fiber. There may be few warning signs with these patients. Bright red bleeding from the rectum may be one of the initial symptoms. A change in bowel habits, including constipation, alternating with diarrhea, or a change in the size of the stool. Approximately 50% of patients with a positive fecal occult blood have either an adenoma or a neoplasm. Diagnostic tests include some serum assays. A CEA will give you information if there is a cancer noted in the abdomen. Scopes with a biopsy and a barium enema are used to establish definitive diagnoses of colorectal cancer, and endoscopic ultrasounds have been used to stage regional rectal cancers. But for any of these, a biopsy is going to be needed that the pathologist can look at, so a determination histologically can be made of what these cells are and what the diagnosis is. Your differential diagnosis is going to include ischemic colitis, diverticular disease, IBS, IBD, and infectious colitis. So the management, the first step is staging. It's important to get them in with a gastroenterologist or a surgeon so that a scope can be performed if necessary. They may need surgical resection and then chemotherapy. As primary care providers, that initial assessment and screening for a colon cancer is our responsibility, and then for those with high screenings for high-risk patients should include a colonoscopy, which will be done by your GI, and then scheduled surveillance depending on what the findings show. Lastly, let's talk about hemorrhoids. These are a mass of dilated veins that can be twisted, and it represents prolapsed submucosal tissue. They can be classified as internal, external. Primary causes include straining when you're trying to have a bowel movement, constipation, prolonged sitting, pregnancy, and an anal infection. Some hemorrhoids are asymptomatic and require no treatment, and often others may have a lot of bleeding and require a ligation. We know that hemorrhoids can occur at any age, but they increase with age. The cause is not completely known, but a lot has to do with our dietary fiber intake and then straining that may happen if you are constipated. There has been thought to be a hereditary component, because approximately 10% of patients with hemorrhoids have a family history of the disease. And then patients that suffer from illnesses that can cause chronic diarrhea, such as inflammatory bowel diseases, are more likely to develop hemorrhoids. On the pathophysiology for external hemorrhoids, they can be dilated varicose veins that originate from an internal hemorrhoidal plexus. Internal hemorrhoids are dilated veins within the superior hemorrhoid plexus, and patients who have a thrombosed hemorrhoid, so a hemorrhoid with a clot in it, may present with a painful perianal lump. Your patient may present with an abrupt onset of pain that's associated with perianal lump, intense pain after going to the bathroom or other straining maneuvers. They may have itching in the anal area. External hemorrhoids may not be visible at rest, but can often protrude when standing or with the Valsalva maneuver. And then internal hemorrhoids are most often present with rectal bleeding. For diagnosing these, you definitely have to be looking at the bottom, especially for external hemorrhoids. You need that visual inspection, and also you may need a digital rectal exam to assess for any internal hemorrhoids. And then definitive diagnosis of internal hemorrhoids is done by an anoscope. On your differential diagnosis, you need to include polyps, cancer of the anus and anorectal fistula, cryptitis, papillitis, and a rectal prolapse. Management includes pain medication as needed, sitz baths, bulk forming laxatives, increasing the daily fiber intake slowly to about 25 to 35 grams, topical hydrocortisone creams for the itching, surgical excision, and then sclerotherapy or infrared coagulation to help manage that, which would be done by surgery. So I believe that we are done with chapter 11, and we will say goodbye to abdominal pain. Thank you for your time and attention.